Here we are on the couch with Dr. Martin London. Martin, you're no longer on the West Coast now. You're scaled back and doing locums.
Yep, that's right.
Not retiring.
Yep.
Despite your rumours of your retirement, you're not retiring.
No. Have been exaggerated.
That's right, yes.
It's part of a never retire program to scale back, so that still in my 80s I'm doing 1 day a week being an interfering old fart.
Yeah. So you spoke at the meeting yesterday, and tell us about what you spoke about.
Well, the brief was doing better for our patients.
Yes.
And I think we've got a real problem in the regulatory environment in which we're living, particularly the funding of chunks of primary care, general practice, being attached to chasing targets. So you get the absurdity of, in trying to measure and guarantee quality, the process of measuring has a negative effect on the actual quality you deliver.
So these are the things like the cardiovascular health targets that the government's...
That sort of thing, and all sorts of other measurements that have to happen. If you open up your medtech, for instance, something pops up which is called the dashboard.
Yes.
And on it you've got a whole lot of things which could be red or yellow or green, and the reds say something you've got to do, something you've got to sort out. And they're good. They're about, we do need to know whether our patients have allergies. It is important to discuss smoking with our patients. I do want to know the blood pressure in all our patients. They're great. You put them all together and you then attach funding to it, and suddenly a practice manager is on your back saying, if we're going to have a viable practice, you've got to get those all done. So the first thing is a bit like those pop-ups on a YouTube. You want to see a YouTube and a bloody advertisement comes up. That's not what I'm here for.
Yeah.
Very distracting. And it takes you away from what's important for the patient. So this is not patient-centered medicine. This is either doctor-centered medicine or even funder-centered medicine. Okay, so that we're doing this tick box stuff, or we're being distracted by the disorders rather than paying attention to our patients. Now, there was a wonderful woman called Barbara Starfield, an American pediatrician, who demonstrated very beautifully that high quality primary care reduces the referral to secondary care, and it's at the point of referral to secondary care that costs of the health system rise and complications arise, iatrogenic problems arise for patients. So you reduce that, you keep people in primary care, you've got a much more cost-effective health system, more bangs for your bucks, and it's not better for patients. No. So, which sounds great, but it's got to be the right sort of primary care, and that's the patient-centered stuff. That's the holistic, what we call the biopsychosocial approach to healthcare, where I'm not just meeting you and your health problems, but I'm looking at your social situation, your psychological stuff.
So what's the answer? What's the way to move the funding from the tick boxes to the actual patient-centered?
Right, okay, we'll come to that in just a moment, because the tick boxing stuff is all on biomedical measurements, but not the particularly important mental health stuff. And it's distracting. The way you get that out the way is you still do those things, but they're not in your face, and it's not critical that you do them come hell or high water, or the funding goes. You put them as part of your holistic care, but really you're paying attention to your patient, and we say being totally present, so that the patient can tell you what's important for their health in their terms, not in terms of some bureaucratically defined healthy person model because all your parameters are ticked off. So getting those targets out the way is the first thing. But we do need to have some ways of reassuring, if you like, the funders that we've got, that we're doing a good job, if you like. I believe one option is to let practices or primary health organisations define their own targets. So you communicate with your patients, you communicate with the communities, you say, what are the health issues that we're concerned about? And then let's say we'll deal with those, the localized or locally adapted targets. We'll have them ticked off, there'll be some sort of central authority, and we'll work on those for a bit. And once you've been doing that, it changes practice behaviour and it develops its own momentum. So once you've got that going, we'll leave it. And we'll say, right, what's the next thing to work on? So that's a stepwise quality improvement. Okay, but it doesn't take attention away from patients and patients' needs.
So how would the funding follow with that then?
Well, the question is whether you do need to have funding attached to those particular behaviours, or say we can direct funding to primary care in a host of other ways. Now, I'm not good at the business side of practice. I just know that when you have punitive approaches to funding, and there's been a change recently, that unless you hit a particular target, which is quite high, you get nothing.
That's right, yes.
Absolutely nothing. And it's not only you don't get nothing, your whole PHO gets nothing. So if you've got a rogue practice in the PHO which says this is nonsense, which in some ways it is, the whole PHO misses. Now, treating practices like naughty school children, that unless the person who broke that window puts their hand up, nobody goes home, is not a good way of building good creative relationships. The same sort of creative relationship that we need to have with our patients, the ministry needs to have with us. It's about listening to each other. It's about paying attention. And there's a trick with that, is that you're not going to listen to anything I'm trying to explain to you in terms of healthcare or what's good until you've got your stuff out of your head. You're just waiting for a gap in the conversation, and then you're going to give me your stuff. So I need to hear from you first.
So that's the thing, like as you're taking the blood pressure, asking how the farm's going.
Blood pressure won't even have started. It's hi Mark, how are things today?
Right.
What's going on?
Yes.
You know, we might talk about things, maybe the farm.
Yeah.
It might be a new patient, and they say, "Oh, it's a southwest of England accent. Is that Bristol?" You know, or whatever, and you make some connection. It's very traditional in Māori. Is before you start going to the business stuff, you say, "Well, where do you come from? Where do I come from?
Sure,
How do we connect? What's common ground?" And that is something I tend to do with all patients. And you begin to start saying, so what's important for you? Right at the end, I might say, or during, I might say, hey, there's some other things that are beginning to worry me. I'm really worried about your blood pressure. I'm really worried about the fact that your smoking is, some people get away from it, it's really risky for you. Okay, that's doctor stuff. So when teaching medical students, I often say, I want you to consider two things. What are your patient's concerns and what are your doctor concerns? Both of those need to be addressed, but patients comes first. When you get a pop-up of tick boxes, it's the doctor ministry stuff comes first, and if you start off with that, you've probably lost the patient for the whole consultation. That's not good primary care.
No, there's not. Are there any more, any of the regulatory or the tick boxes more important? I think of immunisation.
Immunisation's great. No, I'm really comfortable with immunisation. I don't know. I like to feel that I know on all my patients their allergies, their blood pressure. The smoking, alcohol stuff, sure, it's important, but it'll probably come up in conversation, and you can bring it in as part of a global how's things in your world. Another thing I ask my students is, I want you to ask, who am I meeting, and what is life like for this person? Because
it's a different conversation, isn't it?
Different conversation.
Yes.
And then you bring your professional expertise is to feed the things that concern you into that context as you go along.
And really, I mean, what you're talking about is developing a relationship.
Absolutely.
In a different way, not a medical model, not a tick box model, but it's as you say, getting to know the person.
And it's an educative thing as well. And a lovely colleague of mine, Nigel Thompson, once we were talking about teaching in general practice. He says, my consulting style is an educational style, which is discussing with the patient and teaching the patient about what's going on. And that's highly connecting. And when you spend that bit of time, you realise that a whole load of things which you might be worried about are put into context, and you're going to reduce your investigations, you're going to reduce your medications, you're going to reduce your referrals, and that is great primary care. And what the ministry needs to know is that that's what they'll gain from. Let us do what we're good at.
Yes.
Let us do good primary care, and you won't need to do all this measurement stuff.
Because when you look at the big picture, as you said, when people are referred, that's when costs. So maybe it's better to reward people for treating people in more intensive way in primary care before that. So maybe that's a better measure then, a better way of funding.
Now, I met a very interesting chap who's a professor of rural health in Scotland, and we had this conversation, and he is trying to get funding for a health economist to go into one of the small rural practices far north of Scotland and just spend a few months there trying to say, what is it we should really be looking at which makes a difference, which is important. And I think it's a brilliant idea. How he's going to get his funding is another matter altogether, but maybe the surgical bus would like to put something up. That's a pretty exciting prospect, I think. Yeah.
Martin, a fascinating topic. Thank you very much for your time.
Okay.
I hope you enjoy the rest of the conference. Thank you.
Cheers.